Hello, welcome to today's presentation, Sun, Beauty or Beast, presented by Dr. Sunil Dhawan, dermatologist with the Center for Dermatology, Cosmetic and Laser Surgery. Dr. Dhawan completed his dermatology residency at Mount Sinai Medical Center in Miami Beach, Florida. He is board certified with the American Board of Dermatology and the American Board of Internal Medicine. Please welcome Dr. Dhawan.
Thank you for having me. It's the Sun, Beauty or the Beast. I've been with the center now for 35 years, enjoyed every year of it, but time is going on and lots of new innovations in skin cancer treatments. The skin protects, gives you temperature regulation, sensation, and secretion with oil and sweat. The layers of the skin are the epidermis, here, the dermis, which is up here, that's the epidermis, dermis, and then the fatty layer, which is called the subcutis. The skin cells migrate toward the skin surface and form a protective barrier. They start here and go up to here. It takes about 21 to 28 days for that cycle. In certain conditions such as psoriasis, the cycle is faster, and in skin cancers, it's uncontrolled. So that's where we get into trouble. The pigment cells are common in the base of the first layer, in the epidermis. This is a pigment cell called a melanocyte. This woman has less melanocytes and less pigment in her melanocytes, so she's got very fair skin. This young woman over here has darker skin, more melanocytes, and more pigment in the melanocytes. The hair follicle is also an integral component. You have the hair follicle and associated what's called sebaceous gland or oil gland. There's a hair shaft, and then there's sweat glands next to it. But you can see here the first layer here, all the way from the top, which is called the stratum corneum, to the base of the first layer, the second layer, and then way down deep is the fatty layer. The sun, which is the giver and taker of life. Facts about sunlight: the risk of sunburn is greatest between 10 a.m. and 3 p.m. Up to 90% of sunlight can penetrate cloudy or overcast days. Some light fabrics and wet clothes can transmit a large amount of sunlight to the skin. So when the skin is wet, if you're out surfing or in the sun in Hawaii, you can actually transmit quite a bit of sun in the water. Hats and beach umbrellas do not provide full protection. Sunlight is reflected by sand, water, porch decks, and snow. The application of oils to the skin with Vaseline or mineral oil or coconut oil can increase the penetration of sunlight and make the effect more active or worse. UVA rays can penetrate glass and plastic. So there's 3 types of rays which we'll go over, but those are probably some of the most important and potentially dangerous. Ultraviolet radiation is a part of the what's called the electromagnetic spectrum. There are 3 types of ultraviolet rays: UVC, UVB, and UVA. UVC rays don't come down to the earth that much, they get blocked. UVB and UVA rays are responsible for most of the effects that we'll talk about. There you go, there's a nice little schematic. UVC doesn't come down that far, but UVB and UVA now is considered to be probably more important in terms of its effect. The UVB radiation are skin burning rays. They're more intense midday, less intense in the winter, more intense closer to the equator, do not penetrate through glass or plastic. UVA radiation is sort of opposite. It's the skin aging rays, all day intensity, intense year round, can get through glass and plastic and maintain intensity all over. So the same level of UVA radiation in general is in, for example, a cold climate like Canada and a warmer place like Mexico. You get similar, not exactly the same, but similar. What damage can be caused by radiation? Well, skin cancer, sunburning, tanning, and photoaging and skin damage. That's UVB. UVA is pretty similar, but probably more damaging because it gets deeper. So it hits the deeper areas of the skin. What are the variables of sun exposure? Skin type is very important. So this is somebody with very fair skin, blonde hair, out in the sun, probably more than he should be, and damaged pretty easily. Northern European tends to show sun damage, skin cancer risk much earlier than most. This is somebody from Central Europe, a little bit darker skin, darker hair, darker eyes. Doesn't tend to burn as much. He tends to tan, but still can get a sunburn. Tans decently over the summer. Somebody more from Southern Europe, from the Arabian Peninsula, from Middle East, Iran, India, Northern India, darker skin, doesn't ever really burn, but almost always tans slowly through the summer months. Has a risk of skin cancer that's lower, but not zero. People of Hispanic background, Mexican Americans, Central Americans tend to have this skin type. This is somebody with the African American skin type, a little darker, never burns, tans to a modest degree. Risk of skin cancer is low, but not zero. So we have removed skin cancers from African Americans. It's not common, but does exist. So the person over here is at the highest risk, the person here is at the lowest risk, but it's not risk of zero. So you can't just willy-nilly be this person and be out in the sun all day without some sunscreen. Time of day is important, as we indicated. The afternoon is probably more important than other times. Sunny versus cloudy, again, important for UVB rays. Geographic location, UVB rays are worse in the center of the world rather than in the poles. Altitude, if you're closer, you get both more UVA and UVB rays, and the reflection from sun, porch decks, snow, water. You get a lot more sunburns in water areas just because of the reflection, and people don't realize it. The ozone layer used to be a problem. It's not a big deal anymore. We have a good ozone layer now that we're not using the hairsprays that cause damage to the ozone layer. Effects of the sun are sunburning, tanning, aging. We have allergies and diseases such as lupus, things like that get worse with sun exposure, and then finally cancer. So sun damage starts with sunburns and chronic exposure. Skin becomes rougher. You get what's called mottled hyperpigmentation, where you get pigment spots, brown spots. They're called liver spots, but they're not really liver spots. They're sunspots. You get fine wrinkling, deeper wrinkling, pre-cancers called actinic keratoses, and then finally skin cancer. So you start with repeated exposure here, leads to this, and then keeps moving on. Sun damaged skin, what does it look like? Well, it's wrinkled, it's saggy, it's tough and leathery, it's got red, yellow, gray, or brown blotches. It's got liver spots, or those brown spots that you see on the backs of people's hands and sometimes on their faces. And it's got pre-cancers called actinic keratoses, and we'll show you some of these. So this is somebody with very little sunlight over here on the left-hand side, my left, perhaps your right. And this is somebody who's related to her with quite a bit of sun damage, and these fine lines, these brown spots, these little lines here. Some of them are aging, but a lot of this is sun damage induced. So all these little red spots on the nose here that you see, sorry, it's hard to move, and brown spots, this is all sun damage related. So if this lady on my right had stayed indoors, like the lady on my left, she would have had skin that would look like this. And the difference in age here is probably only 40 years. So it's relatively fast. This is somebody who was a lifeguard for 50 years, pretty sun damaged, all these heavy wrinkles on the cheeks. Some of this is expression induced, but a lot of this is right here. Not the sagging of the skin, but a lot of these changes are sun damage changes. Sorry, I'm having a hard time moving this. There you go. All these little bumps here, probably sun damage. If you biopsy, that's a lot of sun damage. And this is little Ozone Annie. Probably nobody remembers this anymore, but little orphan Annie was there. And so the sun will come out tomorrow and she's burned to a crisp. We don't want that to happen to you. What are some of the benign skin growths? Well, that's a precancerous growth called an actinic keratosis. It's benign, but precancerous. Scaly, flaky spots on the back of the hands and on the face. There's one on the face that keeps getting shaved over and getting cut. And you can see all the sun damage here, all the brown spots. The skin just doesn't look healthy. Here's some brown spots called lentigines, very common. They're not cancerous, but they indicate too much sun, so we need to watch for those. And these are bumps called seborrheic keratoses. They can occur in non-sun damaged areas, but you can see these bumps right here. They're almost like somebody threw these bumps on somebody's skin, and then this same patient has those lentigines, the flat brown spots. Some of these bumps start as flat brown spots and get bumpy as people get older. So they can occur in non-sun exposed areas, but tend to be more common in sun exposed areas. What are some of the malignant skin tumors? Well, the incidence of skin cancer and melanoma is increasing very rapidly, 15 times more common now than it was in the 1930s, probably because a lot of us started going to vacations in warm climates. It's very common to hear people who grew up in the 50s, 60s, and 70s say, I used to apply baby oil or coconut oil and go out and, kind of get a tan. Well, that was probably the reason why we're having so much trouble now. Fair-skinned, blue-eyed, blonde or red-haired people have a very high risk of developing skin cancer. It's cancer. It's an uncontrolled cell growth. The 3 types of skin cancers are basal cell carcinoma, squamous cell carcinoma, and melanoma. The last one's the most important to keep track of. What does a basal cell look like? Well, it's usually about 84% of all skin cancers. It's on sun-exposed areas, small, shiny pink bump. Without treatment, it bleeds, crusts, and keeps repeating. And here's this basal cell right here. It's just growing slowly and bigger, and over time gets bigger. Can do serious local damage and eat away at the parts of the face, ears, nose, lip, or eyelid. Rare that this would ever do anything. The chance of it causing any significant harm or potentially even death is very low. Though I had a patient here at that was a patient of ours, this is going back almost in the late 90s, and she refused to have a basal cell treated on her eyelid. It grew and grew and grew and grew, finally went into her brain and killed her. But that's something where the patient could have avoided it very easily 7 or 8 years before. We kept seeing her for other things, and she finally passed away. Here's a smaller basal cell. It's not that big. It's called the good. This is fairly easy to treat. It looks like a pearl on the skin with these blood vessels and a scab that doesn't want to heal. And this is a larger one, similar, but just got bigger. You can see it's a bigger scab right there. And then the real big ones. Now, this is potentially one that can kill you because this has been there for 20 years. So, this is probably not acceptable that this is here, but again, this was someone who declined being treated, so it just got bigger and bigger. It started 20 years ago, very small, probably the size of the one on the face, and just got bigger. What's a squamous cell look like? Well, it's not dissimilar to a basal cell. It's about 14% of all skin cancers. Firm red bump. Does scab, though not always. This is in front of the ear here. It's a crusty bump that doesn't want to go away. And there's another bigger one that appeared, that didn't seem to go away, and people try to cover it with makeup and it just doesn't seem to go away. And let's talk about melanoma. So those of you who are asleep can kind of wake up now. Let's see. So it's about 1 to 2% of all skin cancers. Less common, far more dangerous than the others. Shaded brown or black spots, since malignant melanoma cells still produce something called melanin, or the brown pigment, or the pigment. Can spread to other body parts and best treated when diagnosed early. We've seen a big uptick recently in melanomas, especially on the back. What are the ABCDs of detecting melanoma? And this is exactly what we use. You can use it yourself. It's asymmetry. One side doesn't match the other. You can see this is asymmetric. If you draw a line through the center, obviously one side doesn't look like the other. Edges are irregular and jagged. You see how jagged and irregular. It's different than all the other brown spots in this thing. It just looks different. The color is not the same all over. There's brown, there's black, there's pink. And the diameter is larger than the size of a pencil eraser, 6 millimeters usually, but it can be smaller. So that's a melanoma very early on the cheeks, probably been frozen or treated. It looks like somebody tried to freeze it and it didn't go away. The center clears up. And there's one that's a bit more dangerous, dark, black, probably on the back, or areas where somebody wasn't able to see it. And here's one that's essentially fatal because it's a melanoma that went from being just flat and black and now a bump coming out. This is almost guaranteed to be fatal if you're not, if it wasn't detected early enough. It says melanoma will be fatal. I should just put melanoma is fatal if not detected early enough. So we've got to be really careful with melanomas. This is actually a real job, and so you think you have a hard job. This is some people, women have better sense of smell, and they're able to detect odors much better than men. And so this is this is an antiperspirant job for an antiperspirant company, I believe for Procter & Gamble. So, prevention and treatment. Skin cancer should be treated by a dermatologist or other MD who is trained to do this. General surgeons, sometimes plastic surgeons, have an interest in doing this. What are the methods of treatment? Well, we can freeze them. We don't do much freezing except for precancers. We can do electrodesiccation and curettage, which is scraping and burning. That's a simple way of describing it. It's an old therapy, but works. We have many patients who are older, don't want to do anything complicated. Surgery, which is the best way to cut it out. There is one called Mohs surgery that's the most precise. We can do that. And then radiation is something I didn't mention here, but that's used a lot now. We're actually going to be getting a device in our office that will help do that in office. And the Washington Hospital has larger ones that we can use for larger tumors. So it exists, and it's an option, but ultimately the best way is to really cut it out. Prevention. Avoid sun during peak hours. Go before 10 a.m. or after 3 p.m. Use sunscreen SPF 30 or greater with titanium and zinc in it. Very important to have titanium and zinc. Wear loose clothing that covers exposed parts, and wear a hat. Avoid tanning, sunburns, or using tanning booths. In point number 2, the reason why we like titanium and zinc is that it's a better coverage, less reactions, and safer for your skin than the chemical sunblocks that were popular 10, 20 years ago. So all of us have switched over personally to zinc and titanium. I'm wearing it right now. You can't see it, but it's there. Don't do this. This is from Miami Beach on one of my last days when I was there in training. Don't do that. That's a young woman. She actually didn't get sunburn. This is just makeup that they used for one of the, I believe, Johnson Johnson & Johnson sunscreens. What are sunscreens? It's a sunblock or sunscreen. It's the same term, basically. Wear protective clothing. You can see this lady has got an umbrella. She's got a hat. She's got sunglasses to protect herself from getting cataracts, and she's protecting herself with a sunscreen all over that's hopefully got titanium or zinc in it. SPF is, all it is burn time without sunscreen. It's basically burn time with sunscreen. So if the burn time with sunscreen is 150 minutes and the burn time without sunscreen is 10, it's 150 over 10, the SPF is 15. So as you get higher SPFs, it just means that you're getting less and less ability for the sun to get in. It doesn't mean it's zero, but it's a lot less. This is somebody who's an ex-headhunter from New Guinea, and he's got the best sunblock here. It doesn't let anything in. So it could be like that. Of course, that's very difficult for anybody to be able to manage, but yes, that is would be ideal, wouldn't let anything in. Best is SPF 30 or greater with titanium or zinc. Here's some brands. You can pick any of these. Neutrogena makes a bunch of them, sensitive skin ones, Ultra Sheer, Dry Touch. You've got to look for titanium and zinc. It's very popular these days to look at brands from Korea and from Asia and other places. Many of those are chemical based. So they're very attractive on TikTok, but in reality they probably don't do anything, or it may be worse for you than titanium and zinc. The technology to make titanium and zinc not white is difficult, so lots of companies can't do it, but some of them have done it well. So these are some of the ones we use. So there's makeup with sunscreen. It's called Color Science. It's got titanium and zinc in it. You have a sunblock that's for the lips, SPF 30. This is, I believe, a 15. This is not even being made, I think, anymore. They're all 30s, so they're the best. You need to protect your lips, because that's another place where if you get a skin cancer there, it could be very dangerous. Any brand with titanium or zinc, SPF 30, UVA and UVB protective, and use it regularly. The other ingredients, like what you see there, are good, but can be more irritating and are probably not as good as titanium and zinc. Most are good. Look for ones that are lighter, and if you have oily skin, or moisturizing if you have drier skin. Excuse me. Price does not correlate with effectiveness. So there are sunscreens that are about $100. They're just as good as the one for 20 or 30 or 40. Sprays are not as good as lotions and creams. Apply about 15 minutes before you go out, and reapply every 2 to 3 hours. Otherwise, sunscreen's gone. Water resistance is essentially for 80 minutes. And the water must be reapplied. That's one of the things people forget in Hawaii. And water tends to make it easier for sunlight to get in, even if you're diving. So a lot of times people get it on their backs. They say, well, I was snorkeling and scuba diving. I was under the water. Well, it gets through. Always apply after any medication, such as those for acne. Put makeup over the sunblock. So it's always medicine, moisturizer, sunblock, and then makeup. Some makeup has sunscreen. Look for those with SPF 30 or greater. 2 layers of 15 does not equal 30, it's just 15. The protection is out of the highest SPF applied. So a 30 and a 15 is still just a 30. Recommendations, these are not a complete list, but you can pick whatever you desire that you like that you'll use. Elta, Solbar, Neutrogena, Aveeno are good brands that we like, and all available. Brands marketed under the name of a store are cheaper. Absolutely, they're less expensive, but they tend to be oilier and not as pleasant to use. Because of this, they may not be used as regularly. So I have many patients that, I went to Costco and I bought all the sunblock. I said, do you use it? Oh, no, I don't use it. I go, well, then why do you have it? Well, I bought it because it was cheaper. I said, okay, but do you use it? Well, no. So it's kind of worthless. So you want to pick stuff that you'll actually use, and that's got titanium and zinc. Vitamin D, not a big problem. Just get enough of it in the diet or take a supplement. I mean, I myself have low vitamin D because I wear sunscreen like a fiend. Most of the uproar has been created by the tanning industry, so really, it's not a big deal. Do a monthly skin examination if you're at a high risk, if you're a low risk, if you're, for example, my skin color, don't have a lot of moles, don't have a huge amount of sun damage. I don't need to be as consistent, but I still get my back checked and I have somebody look at it and make sure that I'm, don't have things that I can't see. This is in one of the brochures we hand out. We don't even use that many brochures anymore. Everything's online, but excuse me, this brochure was quite good. You have to look at hidden areas behind the ears, under the legs, right here, on the butt area, underneath the arms. There are places where these things, pesky things, will start developing. I've removed several skin cancers in the groin. One of my good friends had a basal cell in the groin area. That was kind of odd. But basal cells tend to occur more in hairy areas, so it just happened to be with him. Look for growths or moles which are changing in size, color, and shape. Growths or moles which are itching, bleeding, hurt, or won't heal. Follow that ABCDS system. Remember we talked about that. Asymmetry, border irregularity, color change or color variation, diameter, and S is symptoms. How do you recognize a melanoma? Asymmetry, irregular borders, non-uniform color or changing color, diameter, any sudden growth. Something was small suddenly got big. So if you have a whole bunch of brown spots and one has changed, that's the one you got to worry about. Symptoms, itchiness, tenderness, pain, bleeding, not healing, scabbing. Excessive tanning, sun exposure, and the number of sunburns is directly related to your risk of skin cancer and melanoma. Get a yearly complete skin examination by a dermatologist or personal physician. So your primary care, if they feel comfortable, we're happy to do it. If they don't, they'll refer you to us or one of the other providers in the community. So you really should keep that follow-up if you are at risk, which means if you're very fair-skinned, have had a lot of sun exposure, worked outdoors, construction work, farm work, somebody should look at you, at least once, and you'll be shocked what people find. And sometimes we find nothing. In fact, majority of the times we find nothing. But the time we do find something, people are saying, wow, I didn't know I even had that. So, any suspicious growth should be brought to the attention of your dermatologist or physician ASAP. Some resources, let me go back 1 second, sorry. So this is an important point, I keep having to stress this, is that sometimes you have to force the issue and say, I've had patients say, I have this bump, it really bothers me, and I look at it and it looks benign, and I've been fooled, but if a patient tells me, this just doesn't feel right, we take it off for them, because the patients are pretty astute. We have very smart people in this community, as we do all over the country and all over the world, and they know themselves pretty well, and they say, this was not here, and I realize you think it's benign, is there any way we could at least check on it? And I go, happy to do it. It's probably once every 10 or 15 years, I'm surprised what I find. And that's a good thing that we have a very low tolerance for doing stuff to these lesions, because many times the rare times that there is something, you'd feel foolish if you didn't do it. Some resources, we have a website that has a lot of these resources, and the American Academy of Dermatology has excellent photos and resources. There's links to in all of these sites. There's also the Skin Cancer Foundation that I didn't put on here. Our site, the Center for Derm site, has links to all these sites. So Mayo Clinic is quite good. So if you punch in skin cancer, you get lots of photos in there. This gentleman is asking for sunscreen. He's not thirsty. He's out in the desert, so you can see he's like right here. Sunscreen. This is a very old, I got this from the Orlando Sentinel, I remember. This is from 1993, but it's a great little cartoon. I'd like to thank Washington Health for inviting me to do this talk and for you all attending virtually. If you have any, we're going to have some questions thrown out at me. I'm happy to answer them for you.
Thank you, Dr. Dhawan. We do have a couple of questions.
Sure.
You mentioned about an increase in melanoma. Mm-hmm. Why do you think that is, with so much education and awareness that's out there now?
People are not, they may be aware, but just like flossing, hardly anybody does it. I mean, you have to, it's going to take 20 to 30 years from the time that we start educating people. We really started pushing sunscreens in like probably the late 80s, early 90s. So this is about the time where the incidence should start dropping. But the people that we're seeing melanomas are usually those who are in their 70s and 80s and 60s. They got the exposure. It's the intense exposure when they were teenagers really is the time you got to hit people. So now we're hitting people for the last 30 years. Hopefully we'll not see these type of changes or lesions in the next 10 to 20 years. We're hoping, but it's not consistent. That's the problem.
Okay, and the last question or statement is, can you just remind us one more time, when we're out in the sun, is sunscreen enough?
So I don't remember that slide I showed you with a woman who's was in sitting with a bathing suit and had the hat and everything. So it's covering yourself, wearing a hat, covering your body, using the sunblock, and reapplying it. Those are pretty much the cardinal rules. But covering in some way and using fabrics that are tighter weaves so stuff doesn't get in.
Okay, thank you. This does conclude our program, and thank you, Dr. Dhawan, for this insightful presentation.
Thanks. Everybody have a good day. Thank you.
Yes, and thank you, viewers, for tuning in. The entire broadcast of today's presentation will be available on YouTube.